Welcome back to another deep dive. Have you ever thought about what happens when a work injury doesn't just heal but leaves, well, a permanent mark? We're not talking about a temporary setback here, but something more fundamental, a lifelong change to your body and what it can do. Today, we're peeling back the layers on a critical yet, often misunderstood benefit for federal workers, the FECA Schedule Award. Imagine getting compensation not just for time off work, but for the actual permanent loss of function in a specific body part. Sounds different, right? Our mission today is to demystify these awards, especially for orthopedic conditions. We're going to unpack everything, what they cover, how they're precisely calculated, right down to the nitty-gritty of medical evaluations, and even how to appeal if things don't go your way. We've pulled insights from official Department of Labor guidance, specific appeals board decisions, and real-world best practices.
Yeah, and what's truly fascinating here is how these awards really stand apart from other compensation. They cut straight to the core of a permanent impact, offering federal employees a clear path to compensation for a lasting alteration in their physical capabilities. It's about acknowledging a permanent change, not just lost time.
That distinction alone feels pretty vital. Okay, let's unpack this and make sense of this crucial area of federal workers' compensation. So to kick us off, what exactly is a schedule award under the Federal Employees Compensation Act? FECA, we call it, right? And what's with the schedule part?
Good question. So a schedule award is compensation for federal workers who suffer a permanent loss or loss of use of specific body members, organs, or functions, all due to a work injury. And you hit on the key term, schedule. The law itself, 5 U.S.C. Section 107, it actually lists specific body parts, and each one is assigned a maximum number of weeks of compensation for 100% loss.
So it's literally a list with numbers attached. Like, give us some examples.
Yeah, exactly. Yeah. For instance, 100% loss of an arm, that's 312 weeks of compensation. A leg is 288 weeks, a hand 244 weeks, a foot 205, an eye 160 weeks. It's very specific. And FECA regulations even include certain internal organs, too, like the lung or a kidney.
Wow, that's incredibly precise. So how does this detailed schedule apply to common orthopedic conditions? Things like injuries to joints or limbs that we hear about all the time.
Right. Schedule awards most commonly cover those orthopedic injuries to the extremities, your arms and legs. That includes major joints like shoulders, elbows, hips, and knees. But here's where it gets really interesting and honestly super important for many federal workers. The spine or back itself. It's not a scheduled member under FECA.
Wait, hang on. That's a huge distinction. So if someone has a permanent back injury, they can't get a schedule award for their back. That just seems counterintuitive for such a, potentially debilitating injury.
It is a common point of confusion, yeah. And you're right, not directly for the back as a whole unit. However, and this is the critical part, if a spinal injury causes an impairment in a limb, like nerve root damage leading to loss of function in an arm or leg, what we often call radiculopathy, that radiating pain or numbness down your arm or leg from a nerve issue in your spine. That resultant extremity impairment can be rated and compensated.
Ah, I see.
So the focus shifts. It moves to the affected limbs, not the spinal column itself. This is a critical nuance and honestly often a surprising insight for federal workers with spine injuries. They might otherwise think they have no schedule award claim at all.
Okay, so just to boil that down, it has to be a permanent impairment, right? Not just a temporary injury that eventually heals. You can't get this award for something that's going to fully recover.
Precisely. The injury must result in a permanent partial disability to one of those scheduled body parts. If it's still getting better with time or treatment, it's just not yet eligible. That comes later.
That brings up a great question for anyone listening who thinks they might have a permanent impairment. When is the absolute right time to actually seek a schedule award? Is there a specific trigger?
This leads us right to maximum medical improvement, or MMI. This is a concept you absolutely have to understand. A schedule award can only be assessed once the injured area has reached MMI. Think of it as the point where your condition has stabilized. It's basically as good as it's going to get with all reasonable treatment. Any impairment left over is considered permanent.
So the medical evidence isn't just about the injury itself. It has to explicitly confirm MMI, like call it out.
Yes, absolutely. The Office of Workers' Compensation Programs, OWCP, requires that the medical evidence must establish that the injured worker is at maximum medical improvement, MMI, and has sustained a permanent AMPAN. That's the standard before an award can even be paid. In practical terms, this means the treating doctor or the evaluating physician needs to explicitly state the date of MMI in their medical report.
Okay, why is that specific date so critical? What's the practical impact if you get it wrong or it's missing?
Well, The schedule award's payment period typically begins right from that date of MMI. So for example, if a knee injury reached MMI on June 1st, 2025, the compensation would usually start ticking from that date. The key takeaway here isn't just that MMI is a medical milestone, it's a crucial financial trigger.
Right.
Failing to get this documentation right can seriously delay your award, not just the rating itself, but when the payment period actually begins. And an impairment rating done too early, while the condition is still maybe improving, OWCP won't consider it final or valid.
So patience and precise timing are key.
Exactly. A physician noting something like, patient reached MMI on May 17th, 2022, 1 year following his left hip replacement, as his condition is static and well stabilized. That kind of clear, specific documentation is absolutely vital.
Okay, so once MMI is officially reached and documented, how is that all-important percentage of permanent impairment actually determined? This sounds like where the rubber meets the road, calculation-wise.
It really is. This is a highly specialized medical process, and under FECA, it must be done strictly following the American Medical Association's guides to the evaluation of permanent impairment, and specifically the 6th edition. That's key. OWCP made a pretty significant change when they officially switched to this edition for all new schedule award decisions back on May 1st, 2009.
You mentioned earlier the 6th edition was a paradigm shift. What makes it so different, and why is that significant for someone trying to get a schedule award?
It really was a big change. It's not just a new set of tables, it's a fundamental shift in how doctors even approach impairment ratings. The surprising insight is that it moves the focus away from simply measuring how much you can't move to first diagnosing the underlying cause of that limited movement,
Right.
and then determining its severity. So instead of just measuring range of motion first, you first identify the diagnosis and its severity using a regional grid. We call that the class of diagnosis. Then you fine-tune that rating using grade modifiers for things like your functional history, how it actually impacts your daily life, plus physical exam findings, and even results from clinical studies like MRIs or nerve tests. All of this gets plugged in and leads to a very specific percentage impairment of the affected member, like an arm or a leg.
Can you walk us through a quick orthopedic example, just so we can visualize this a bit better?
Sure, certainly. Let's say you have a claimant with bilateral total hip replacements, both hips replaced. The doctor would go to the hip regional grid in the guides. That's table 16-4. A good result for a total hip replacement might start as a class 1, which has a default 7% leg impairment. Then the grade modifiers would be applied to adjust this, potentially resulting in, let's say, a 10% permanent impairment of each lower extremity, one for each leg.
And I assume this has to be incredibly detailed in the doctor's report, right? It can't just be a percentage plucked out of thin air.
Oh, absolutely critical. The evaluating physician must explicitly reference the AMA Guide's 6th edition and clearly show how they got that percentage. They need to cite the specific tables, the formulas used, the whole calculation. OWCP's own medical specialists will meticulously review this, believe me. And if the report doesn't conform to the guides or it lacks that clear step-by-step rationale, that's a pretty direct road to denial.
Okay, going back to those tricky spine injuries, if the spine itself isn't a scheduled member, how are nerve-related impairments from back injuries rated, especially with this new diagnosis-based approach?
Yeah, that's a unique challenge. The AMA Guide 6th edition didn't initially provide a separate, totally clean mechanism for rating spinal nerve injuries as extremity impairment. But because FECA requires rating the extremity, the arm or leg OWCP adopted a specific workaround. They essentially used the guide's framework for peripheral nerve impairments, often referencing a special AMA Guides newsletter article from July-August 2009. They used that to rate nerve root impingements in terms of arm or leg impairment. So if a herniated disc causes permanent radiculopathy, that nerve pain or weakness, into your leg, the impairment is evaluated by the severity of the nerve dysfunction in that leg, not the disc itself. Physicians really need to be aware of this specific OWCP guidance, as it's a common area where reports can fall short if they don't address it correctly.
What about using range of motion measurements? I feel like that used to be, or maybe still is, a very common way to measure impairment. Is that still relevant with the 6th edition?
It's less central now. The 6th edition definitely favors that diagnosis-based impairment, the DDI method we discussed. Now, range of motion, ROM, can still be used as an alternative in some cases, but OWCP has very specific and frankly quite strict rules about it. OWCP's own guidance, like in FECA Bulletin 1706, spells it out. If ROM is used for an extremity rating, the evaluator must document 3 independent measurements of each motion.
3 times?
3 separate times, yes. And the results have to be consistent. OWCP will only allow the ROM-based rating if it results in a higher impairment percentage than the diagnosis-based method, and if that proper triple measurement protocol was meticulously followed. The Employees Compensation Appeals Board, ECA, they've consistently upheld these requirements. They really emphasize that accuracy and sticking to the 6th edition's protocols are paramount.
Wow.
So, yeah, it's not enough to just measure. You have to measure their way very precisely.
Okay, so we've navigated MMI. We've established the permanent impairment percentage using these rigorous medical guidelines. Now, the million-dollar question, maybe literally for some listeners, how does that percentage actually translate into compensation? How do they get paid?
Right. So once that permanent impairment percentage is officially established for a scheduled member, the schedule award amount itself is calculated using 3 pretty straightforward factors. First, that impairment percentage we just talked about. Second, the maximum number of weeks assigned to that specific body part by the law, the statute. And third, the compensation rate, which is basically a percentage of the employee's wage.
Let's get that formula on the table, make it clear, and then run through a concrete example.
Sure. The basic formula is weeks of compensation equals the impairment percentage of the member multiplied by the maximum weeks allowed for that member. Then your weekly compensation rate. This is typically 66 and 23% of your average weekly wage. Or it's a higher rate, 75% if you have dependents.
Okay.
And that rate is fixed. It's based on your highest wage and either the date of injury, the date your disability first began, or the date of any recurrence, whichever is highest. The final dollar value of the award is then simply those calculated weeks of compensation multiplied by your specific weekly compensation rate.
All right, let's put that into a real-world scenario. Let's say we have Sarah, a federal postal worker, and she has a shoulder injury. How would that work?
Perfect example. Okay, imagine Sarah has a work injury to her shoulder, and after reaching MMI, it results in a 20% permanent impairment of her arm. Now, an arm, as we mentioned earlier, corresponds to 312 weeks for a 100% loss, according to the schedule. So 20% of those 312 weeks comes out to 62.4 wins.
Got it.
Now, if Sarah's weekly compensation rate is, let's say, $1,000 per week, her total schedule award would be 62.4 weeks multiplied by $1,000, which equals $62,400. OWCP usually pays this out in periodic installments, like biweekly checks. Though it's worth noting, a lump sum payment can be requested. If OWCP approves it, that can be a pretty substantial upfront sum.
That's a great, clear example. Now, this raises an important practical question. Can someone receive both a schedule award and regular wage loss benefits at the same time? It seems like maybe it would be one or the other.
That's a very common question and really important. Generally, FECA does not allow an injured worker to receive a schedule award and wage loss compensation for disability simultaneously for the same injury.
Okay.
If you're already on the OWCP rolls getting payments for total or partial disability, you typically have to elect to choose to stop those wage loss payments while the schedule award is being paid out. However, and this is a key distinction, you can receive a schedule award from one injury concurrently at the same time as wage loss benefits from a different injury that affects a different body part.
Okay, that makes sense. What about medical benefits, though? Do those stop once the schedule award is paid out? Because that could be a huge concern for someone needing long-term care.
No, and this is absolutely crucial for injured workers to understand. Receiving a schedule award does not end your medical coverage for the accepted injury. Not at all. The injured worker can continue to receive medical treatment for their accepted conditions even while or long after receiving a schedule award. The schedule award solely compensates for the impairment itself, the loss of function. OWCP remains fully responsible for all related and reasonable medical care. That's often a huge relief for people.
Definitely. What if someone has multiple impairments from the same incident, say injuries to both an arm and a leg? Does that complicate things calculation-wise?
Not necessarily complicate, but it certainly multiplies the benefits, potentially. Each scheduled member is rated and paid separately, often consecutively, meaning one award pays out, then the next one starts. If they arise from the same incident, OWCP might combine percentages for, like, members, for instance. Separate finger impairments could be combined into a single hand rating. If an injury causes bilateral impairments, say to both knees or both shoulders, awards can definitely be given for each side. The total weeks for multiple awards can simply run one after the other, extending the payment period.
And what if an impairment, maybe even after MMI was declared, actually gets worse over time? Can you revisit it? Is the door closed?
No. Thankfully, the door is not closed. You can file for an increased schedule award to cover the difference. The new impairment evaluation, though, must clearly show a higher percentage than the prior award. OWCP will then pay the additional weeks corresponding just to that increase, not the whole thing again. And there's no strict time limit on filing for an increased schedule award, as long as you have new medical evidence demonstrating a greater impairment. This is especially important for conditions that might be progressive or just deteriorate years down the line. It's a vital safety net built into the system.
So given all this complexity, the MMI, the guides, the calculations, what happens if OWCP denies a schedule award? Or maybe they grant a lower percentage than someone expected. What are the options for a federal employee in that frustrating situation?
Yeah, that definitely happens. You have several distinct avenues to appeal or dispute the decision. And the OWCP decision letter itself will always include specific instructions on how to proceed. It's really important to read that letter carefully.
Okay, so what's typically the first step someone might take? Where do you usually start?
Often, the first logical step is a request for reconsideration directly with OWCP itself. You have 1 year from the date of the decision to file this. The absolute key here is providing new evidence or a new legal argument that wasn't previously considered. For example, submitting a brand new, more detailed medical report with a clarified impairment rating that specifically addresses whatever reasons OWCP gave for the denial. OWCP will then review the entire case again in light of that new information. And submitting compelling new medical evidence usually triggers OWCP to issue a completely fresh decision on the merits, which is useful because it also resets some other appeal deadlines.
Okay, so reconsideration is one route. Are there other immediate options besides that?
Yes. Instead of reconsideration, you could request either a hearing, which can be in person or by phone, or a review of the written record before an OWCP hearing representative. Now, this route has a much tighter deadline, just 30 days from the OWCP decision, so you have to act fast. During a hearing, you get to personally present your case, you can submit additional evidence right then, and you can even testify. It gives you a more direct interaction with the decision maker.
And then there's ECB, right? The Employees Compensation Appeals Board. That sounds like the final step, the highest level.
Correct. The highest level of administrative appeal is to the Employees Compensation Appeals Board, ECPB. It's a separate appellate board within the Department of Labor, totally independent of OWCP. You have 180 days, so about 6 months, from the OWCP decision date to file this appeal. ECA's review is strictly legal in nature. They examine the existing record to see if OWCP's decision was based on substantial evidence and followed the law and procedures correctly.
What's the most crucial thing to remember about appealing to ECB? Is there anything surprising about their process?
The most crucial thing about ECK, and this catches many people by surprise, is that no new evidence can be submitted to them. None.
Really? No new doctor reports?
No new reports, no new testimony. They only consider what was already in the case record at the time of the final OWCP decision you're appealing. So ECKB is usually the route you take if you believe the evidence already in the file was sufficient, and OWCP simply made a legal error, misinterpreted the evidence, or didn't follow their own procedures. They can send the case back to OWCP, remand it for further development if, for example, OWCP improperly weighed the medical evidence or didn't follow the AMA Guides protocol correctly.
That distinction about new evidence is incredibly important. So just to clarify, you can't pursue all these different appeals at the same time. You have to pick a lane, essentially.
Precisely.
Yeah.
You cannot have multiple appeal routes active simultaneously for the exact same OWCP decision. You choose one first. Strategically, many claimants often use the OWCP reconsideration process first. Why? To get that crucial new medical evidence into the record.
Because ECKB won't look at it later.
Exactly. Then, if they're still denied after reconsideration, they could proceed to ESAB with that now strengthened record. And it's worth noting, each new OWCP decision, whether it's after reconsideration or a hearing, will carry fresh appeal rights, allowing you to potentially cycle through the process if needed.
Okay, let's try to connect this to the bigger picture with some real-world ESAB case examples. These can really illuminate how these intricate rules actually play out in practice.
Absolutely. ESAB decisions are great for clarifying the nuances. Let's look at a few key ones related to orthopedics. First, there's the issue of spine injury with extremity impairment. A really important case is Williams v. DOL from 2005. This landmark decision highlighted that while the back itself isn't a scheduled member, any impairment to the legs or arms originating from that back condition is compensable. It explicitly reinforced that schedule awards apply regardless of whether the cause of the disability originates in a part of the body other than that member.
So the source doesn't matter as much as the resulting limb impairment?
Exactly. The lesson here is always ensure that if a neck or back injury causes nerve loss or radiculopathy into your limbs, that specific limb impairment gets properly evaluated using the guides. It could absolutely be the difference between a denied claim and an accepted one. Then there's the problem of insufficient medical documentation. Look at a very recent case, SB docket number 240153 from March 28, 2024.
Hmm.
In this case, an upper extremity impairment claim was denied simply because the physician based their rating on range of motion but didn't follow the AMA guide's strict protocol of taking 3 consistent measurements.
That triple measurement rule again.
That exact rule. ECCAB upheld OWCP's denial. The key takeaway: a schedule award can be denied purely because the doctor's report doesn't follow the required precise methodology we talked about earlier. Thorough, protocol-compliant measurements and rationale are absolutely essential. It's not just about what you report, but how you report it. Another interesting one involves the appeal of a rescinded award. This was BCVHHS docket number 231018 from October 7, 2024. Here, a federal nurse actually had part of her schedule award taken back by OWCP after they got a second opinion. But ECCAB found that OWCP hadn't met the strict legal requirements for rescinding a benefit. They failed to get a necessary supplemental report from that second opinion doctor, leaving an informational gap in the record. So ECCAB actually reversed OWCP's rescission.
Wow, so OWCP has a high bar to meet if they try to take an award back.
They do. The surprising insight here is OWCP carries the burden of proof if they try to rescind or reduce an award you've already received. If they don't fully develop the medical evidence themselves to justify it, an appeal can succeed, even if it's over what seems like a small percentage. And finally, let's look at an increased schedule award claim. This is RPV Air Force, docket number 10-1123 from January 25, 2011. A claimant filed for an increased award because their condition worsened, but OWCP denied it, saying it was untimely. ECCAB disagreed completely. They ruled that when an employee submits new medical evidence that supports an increased impairment, the claim is not subject to time limits or clear evidence of error standards for reconsideration. It essentially has to be treated as a new claim based on the new evidence.
That's huge.
It is. A profound lesson. If your impairment genuinely worsens, you can seek an increased award even many years after the original award was issued, as long as you provide clear, new medical documentation showing that higher impairment level. This offers really important protection for those with conditions that might degenerate over time.
Okay, listening to those cases, it sounds like the medical report isn't just important, it's absolutely essential. It seems like everything hinges on it. So for a physician writing one, or maybe someone assisting them, what absolutely has to be in a top-notch impairment rating report for OWCP? What are the non-negotiable elements?
You're right. A well-prepared report is often the single most decisive factor. It truly is the linchpin of the whole claim. Here's a checklist of must-haves. First, wait for MMI and state it clearly. Don't rate too early. The report must explicitly indicate that MMI has been reached, provide the specific date, and ideally offer a brief explanation. Something like, Mr. Hodge reached MMI on May 17, 2022, 1 year post-left hip replacement. His condition is now well stabilized and no further significant improvement is anticipated. Second, list the accepted OWCP conditions and relevant history. Clearly state which accepted work-related conditions are being rated and provide a concise history directly connected to the current impairment back to that original work injury. Draw the line clearly. Third, explicitly use the AMA Guides, 6th edition method, and cite it thoroughly. This is where meticulous attention to detail pays off huge dividends. Identify the diagnosis, find the class of diagnosis, CDX, from the correct regional grid table in the book. Record all the grade modifiers, functional history, physical exam, clinical studies with clear justification for the score given to each one. Show the precise calculation of the net adjustment step by step. And finally, state the specific percentage impairment of the specific member, arm, leg, etc.
And crucially, as you mentioned, not whole person impairment, right? That's a common mistake coming from other workers' comp systems.
You hit on a vital point there. Absolutely critical. Do not use whole person impairment, WPI, for OWCP schedule awards. They only care about the percentage impairment of the specific scheduled body part, arm, leg, hand, foot, etc. Using WPI is a very common reason for reports to be rejected or claims denied. Stick to the specific member impairment. Fourth, include objective findings and measurements. This isn't just about the doctor's opinion. It needs data. Detailed range of motion measurements, remember, 3 times if used for the actual rating. Strength testing results like 0-5 scale, detailed neurologic exam findings, sensory testing, and crucially, the results of key diagnostic tests like MRIs, EMGs, X-rays that support the diagnosis and rating. Fifth, explain any special cases clearly. If the impairment requires using one of those specific guides newsletter updates, like the tables for rating nerve root impairments stemming from spine issues, the doctor needs to explicitly mention that they're using that specific guidance. Show your work, basically. Sixth, use clear, concise language. Remember, the report needs to be easily understood by a non-medical claims examiner. Avoid excessive medical jargon where possible. Reference specific sections or tables in the guides. Present the information in a structured, logical, easy-to-read format. Bullet points can help. Seventh, include the physician's credentials and experience. Briefly noting special qualifications, like being certified by the International Academy of Independent Medical Evaluators, IAE, for AMA guides use, can significantly bolster the report's credibility and weight with OWCP. Eighth, address any pre-existing conditions properly. Now, OWCP generally doesn't apportion for schedule awards, meaning they don't try to mathematically divide the impairment between a work injury and a pre-existing condition if the work injury aggravated it or combined with it.
Okay. However, the doctor should clarify if the work injury aggravated a pre-existing condition. And ideally, if medically supported, state that the entire current permanent impairment being rated is now attributable to the effects of the accepted work injury. That clarity helps prevent questions later. And finally, number 9. Double-check everything and be consistent. Simple arithmetic errors in calculating the final percentage, or inconsistencies between the narrative description and the numerical ratings. These can cause frustrating delays or even denials. Proofread carefully. It's like trying to navigate a minefield. One tiny error can halt the whole process.
That's an incredibly thorough checklist. It really underscores that the burden isn't just on the injured worker to gather all this. So, flipping the perspective, how can clinics and healthcare providers actively help their patients navigate this incredibly complex process? Because it sounds like their role extends far beyond just the medical treatment itself.
You're absolutely right. Proactive support and just having a deeper understanding of the OWCP process from the clinic side can make a monumental difference for the patient. Think of them as co-navigators in this journey. Here's how they can help. Educate and identify potential claims early. Clinics can, and probably should, inform patients about the possibility of a schedule award as soon as it seems likely there might be a permanent residual from their injury. Don't wait until years later when the patient might not even remember it's an option. Track MMI proactively and initiate the evaluation. Don't just wait indefinitely for OWCP to maybe ask for an impairment rating. Proactively schedule that specific impairment rating exam once MMI is reached. Maybe even refer the patient to specialists who are known to be experienced with the AMA Guide 6th edition and OWCP requirements. Assist with the claim paperwork. This sounds basic, but it's a common stumbling block. Guide patients in correctly filling out the Form CA7, which is the claim for schedule award or compensation, and make sure it gets submitted along with the detailed medical report. Package it all together.
Ensure completeness of the medical record sent to OWCP. Before the rating is even done, make sure all relevant treatment notes, diagnostic reports, operative reports, PT notes, everything has been sent to OWCP to provide the full context for the claim. Facilitate communication. Be responsive. If OWCP needs clarification or an addendum from the doctor, help facilitate that promptly. Quick responses can prevent lengthy delays where the claim just sits waiting. Maybe even quality check the impairment report internally. Consider having another provider or trained staff member review the impairment report for clarity, completeness, and consistency before it goes out the door to OWCP. A second set of eyes can catch errors and save a world of trouble later. Help address OWCP's feedback or specific requests. If OWCP's District Medical Advisor, DMA, raises questions or challenges the rating, actively assist the physician in crafting clear, concise supplemental reports that directly address those concerns point by point. Support patients during appeals if needed. If a claim is denied, help the patient understand the reasons. Maybe assist in obtaining second opinions, or help the physician write more detailed reports for reconsideration. Or, importantly, help patients find a reputable, experienced federal workers' compensation attorney if legal representation seems necessary. Maintain documentation of impairment over time. Keep good records of any changes in the patient's function related to the injury. This documentation can form the crucial basis for a successful increased schedule award claim down the road, especially for conditions that might worsen. And finally, maybe most importantly, encourage patients to follow through. Many federal employees might be unaware of their rights regarding schedule awards, or they just get overwhelmed by the process and give up. Remind them this is compensation they are potentially entitled to for a lifelong loss of function. It doesn't affect their ability to work or their ongoing medical benefits. It's about securing what they've earned for a permanent physical change.
What's truly fascinating here, listening to all that, is how much the medical provider's role really extends beyond just clinical care. It moves deep into advocacy, procedural guidance. It's almost like they become an administrative detective or a guide for the patient.
Exactly. And, compassion and clarity are just so key in this process.
Yeah.
Demystifying it, explaining why certain steps or documents are needed, that really reduces patient anxiety. And ultimately, it profoundly helps them secure the benefits they've rightly earned. It's about empowering them with understanding, not just, giving them a diagnosis and sending them on their way.
We have truly taken a deep dive today into FECA schedule awards for orthopedic conditions. From understanding what they even are to how impairment is so meticulously rated using the AMA Guide's 6th edition, how the awards are calculated, navigating that crucial, sometimes confusing appeal process, and ensuring your medical documentation is absolutely airtight. It's crystal clear this is a nuanced but absolutely vital area for federal employees to understand.
Yeah, if we connect this all back to the bigger picture, it just highlights again how incredibly important detailed medical evidence is. And also, having a sharp understanding of these, let's face it, bureaucratic processes is paramount for actually securing your entitlements. It's really a testament to how complex compensation for work-related injuries can be, but also how specific rules and pathways do exist, if you know them, to ensure fair treatment for permanent impairments.
So what does this all mean for you, our listener? Well, whether you're a federal employee who's been injured or perhaps a healthcare provider working with them, understanding these intricate details can absolutely be the difference. The difference between a denied claim and securing the just compensation you deserve for a lifelong impact, it really is about empowering yourself with knowledge, turning that potential confusion into clarity. And here's a final thought for you to mull over as we wrap up. If the precise measurement and careful documentation of even a single percentage point of impairment can be fought for and won on appeal, like we saw in that ECCAB example where the rescission was overturned, what other overlooked details and other complex systems you encounter might be absolutely critical? How might a deeper dive into any given rule book, any set of guidelines or procedures, reveal surprising pathways to much better outcomes? Something to think about. Thank you so much for joining us on this deep dive. We sincerely hope this has given you the insights you need to be well-informed and truly empowered.